Hi, it's Dr. Centeno, and happy Monday to you. You've Got the Power, and today we're going to cover an interesting topic. We've talked about this one before, and that is neck stabilizer muscle atrophy. This is an interesting topic because much like the back, the stabilizer muscles in the neck can go offline, and that can really impact stability, which then makes instability worse. Now, what's interesting about all this is that despite there being a lot of research on this and low back, deep stabilizer atrophy, there really isn't a lot of willingness, if you will, from reading radiologists to put this stuff in their reports. I've asked them about this. Others have asked them about this. And kind of what comes back is this, well, most of the docs that we're reading for don't know what it is. And hence, if we put this in our report, they'd call us up and say, what the heck is this? So lots of research, not much participation from radiologists in reading this stuff. So if you have this on your neck MRI, you probably don't know about it because they haven't read for it. So today I'm going to show you how to read your own neck MRI. Now, maybe not everyone can do this, but I've tried to make it as simple as possible to show you how you can read your own neck images, find the right image, and try to see if it does have neck stabilizer muscle atrophy. It's not hard to do. In fact, it's one of the easier things that you could read an MRI for. So we'll go over that today, and then I'll answer any questions about that topic and or any topic that you've got. And then just to let you know, I won't be here on Friday or probably next week. I'm starting a extended vacation. Now, I may be able to get in a Facebook Live here or there. I'll have to see what the environment looks like on the ground where I am before I can commit to that. So just giving you a heads up on that. In the meantime, let me share my screen and we'll start some slides on this really interesting topic here. Okay, it looks like it's shared. So we'll start that here. So again, the topic today is talking about these neck stabilizers. And, well, we don't want that. Sorry about that, guys. I think I've got subtitles on. I apologize. My bad. Here we go. Pen. Okay, so looking for upper cervical stabilizer muscle atrophy on your neck MRI. This could be in the upper neck, middle neck, lower neck. Critical finding that's not put in MRI reports very often. So there's quite a bit of research on this topic, really, and the common theme here is a guy by the name of Jim Elliott. Now, Jim used to work for us as a physical therapist in our clinic, and then he kind of got the research bug, and then from there, he went and got a PhD in Australia, went down there to do his PhD, and developed an expertise in imaging. And so he's really published almost all of the world's research on this topic of neck muscle atrophy. But these are the 8 studies we'll be depending on today. So your spine is stabilized by small muscles called multifidus. And these small muscles stabilize one segment on the other, and they keep everything aligned. And they actually contract before you move an extremity, which is super interesting, right? So 100 milliseconds, or a tenth of a second before you, let's say, go reach for something, these muscles are contracting, and they're doing that so that there isn't any motion once your hand puts more force on the spine by reaching out. So it's kind of interesting how that works. Again, they're in really the entire spine, throughout the low back. This is the upper back, and then the neck. So lots of these deep segmental muscles. Now, the little red muscle there that you see on your screen here is just an isolated area. So if you look at that up close, you can see what that does. It helps to stabilize things. Now we're going to go the other direction here. And I'm going to, hold on a second here, guys. I'm going to stop the auto. I apologize. I'm going to need to stop the auto run on that, so I can go through it a little bit slower, because that's just kind of racing through. So anyway, the little red muscle here is what we're talking about. I've just drawn in one. There obviously would be many more. And I've drawn in one to give you an idea of what this muscle would do. So this is someone who's turning their neck. And this is an animation I did personally a long, long time ago. But it'll show you what this does. So this keeps the neck muscle bones stable to help protect those bones and the facet joints and the disc and the nerve, etc. So if we go close up here, you can see that as this person turns their neck, this muscle is helping to align those vertebrae in the turn, because we don't want them getting out of place. If they get out of place, then things can get pinched, like nerves, like facet joints, like the disc up front. Now, look at these two different pictures here, right? On the left, we've got an intact multifidus muscle. We see things kind of lined up and turning in sequence as you turn your head, meaning the vertebrae are turning in sequence, one turning the other. Now, when the muscle on the right gets too small or atrophied, notice how it's not doing its job of keeping everything in place. Now, again, this would be all the multifidus muscles. I've just drawn in one here because it was frankly too complex for me to draw them all in for an animation. But you get an idea of how the left is nice and smooth. You see it turning from the top, one turning the other as you go down, as the person's head turns. On the right, you don't see that. You're seeing things not move as well. You're seeing that vertebra with this multifidus muscle attached getting out of sequence. And that's, again, what can lead to facet joint injury, nerve injury, injuries to the disc in front, etc. So, as I said, the problem with this is that reading radiologists, even though this stuff is common, rarely put it on their reports. And so most of the people that have this, whether it's in the neck or low back, don't know that they have it. So what do we do about cervical multifidus atrophy? What do we know about this? So we're going to start with what do we know? And then at the end of this, we'll get into what do we do about this, or why is it important? So what do we know first? Well, we know in patients with chronic headaches that these muscles are atrophied on MRI. We know that patients after a whiplash type injury have this kind of atrophy, and it's really called fatty infiltration, meaning that the muscle gets these fatty streaks in it or is replaced by fat. Now, it has nothing to do with being fat. Anytime there's muscle atrophy in the body, we see it in the rotator cuff, we see it in the low back as well. When there's atrophy, the muscle gets replaced by fat. It's also called pseudohypertrophy, but that's another story. Older women with cervicogenic headaches also have atrophied and fat-infiltrated neck stabilizer muscles. What's interesting is that whiplash-injured patients, Jim's been able to actually do functional MRI on the brain, and he sees brain disorganization through looking at some of the networks in the brain, and that's associated with fatty neck muscle atrophy. Now, is that because of some sort of brain injury causing muscle atrophy? Does it go the other way? No one's 100% sure at this point. I would suspect that what's happening there is that the body can't figure out what to do with that atrophied muscle, and there's probably a local issue there causing it. And we know that patients with cervical myelopathy, and that's where the spinal cord is getting pinched, have this type of fatty atrophy, and that's associated with more disability and a worse surgical outcome. We also know that this kind of atrophy happens relatively soon after a whiplash injury, but only in the patients with poor recovery. So that's interesting. You can separate whiplash patients out by recovering quickly or poorly solely based on this atrophy, and that makes sense, right? Because once you get this atrophy, things aren't moving correctly, and once you're down that road, you're hurting that vertebra more and more because of that atrophy. We also know the deep neck flexor muscles up front. So we're not talking now about the back ones, which is multifidus. We're talking about the ones up front, also atrophy in whiplash patients. And in asymptomatic women who are kind of young to middle-aged, we don't see that this fatty infiltration is related to age. That's one of the things that Jim wanted to look at, right? Is this just related to getting older? Do older people just get this type of atrophy naturally? And the answer is they don't, unless they either have cervicogenic headaches, they've been in a whiplash accident, have cervical myelopathy, which is pinched spinal cord, etc. This kind of atrophy is also seen when you have an irritated nerve. So if the reading radiologist is not going to read for this stuff, can you read your own MRI images to see if you have this issue? And the answer is yes, it's not that hard to do. So the first thing you have to do is to find what will probably be called the T2 images. And in this case, you can see here SAG T2. So SAG is sagittal or a side view. And over here, you see AX T2, and AX is axial, which is a top-down or really a bottom-up looking image. So that gives you some idea of what's going on there. So you see here fat, which is this white color. That's the fat underneath the skin. We see here the spinal cord, which is dark. So we're looking for the spinal cord to be dark. We're looking for fat to be white. We're looking for the muscles to be dark. They're back here. And water, which is the cerebral spinal fluid that surrounds the spinal cord, should be white. So those are the things we're looking for here. And then in order to identify the multifidus, it's that deepest muscle layer. So you're going to see muscles out here, which is not multifidus, muscles out here, which is not multifidus, muscles out here, which is not multifidus, not multifidus, not multifidus. I'm just going to keep doing this. It's kind of fun. Those are the scalenes there. So multifidus, you can see here, is this deepest muscle group that's right up against the spine. And it tends to have this sort of shape. So this is where the disc would live up here. This is the spinal cord. This is the back of the vertebra called the spinous process. This is called the lamina. And right up against that is where this multifidus lives. So that's what you're going to want to look for. And you see it here mostly dark. Now, I often tell patients to look at this like a steak they would buy in the grocery store, right? So if this is a steak, the area that I have marked in here, forget about all the other parts, but if just this part in here is a steak and you're buying it in the grocery store, you would say that's a good steak, right? It's got a lot of dark muscle, not a lot of fat. That's a steak you'll buy all day long and twice on Sunday. Now, we're going to look at the bad steak here, is what I tell my patients. So the bad steak is where we have atrophy. And it's a bad steak because it has a lot of fat. So if we look here into this same compartment, we now see mostly white. So if we're in the grocery store, we're not going to buy this steak. It's almost all fat and very little dark muscle in there, right? You got a little more dark muscle here. You got a little dark muscle there. But if you were in the grocery store and you got some right there, you really wouldn't buy this steak because it's almost all fat. So that's what atrophy looks like is where you're seeing more white. Now, this is pretty severe atrophy. You can see that this is up in the upper neck around C2-3, which is where most CCI patients will see this. But other patients that have spinal nerve issues may see it down here where these disc bulges live. So what does all this mean? We looked at what we know. So what does it mean? Well, it means that getting fully recovered requires treating the problem that caused the atrophy, or an irritated nerve, an injured facet, or instability, which is where we see this most often. And then getting the muscle strong again, because remember, I've told you many times, at the end of the day, stability in the spine requires a strong muscle and a strong ligament. Now, obviously, if you've got a ligament problem, we've got to tighten down those ligaments. But then if there's atrophy, you have to get the muscle stronger to get fully recovered. So again, stability is muscle and ligament. And now we're talking about this muscle part. So I think that's all I've got for today. I'm going to go take any questions that are out there. Let me stop this here. And see what we've got. Hello, Irare. I think that's the first name. HRH. Can you show the instructions for X-ray when DMX isn't available? You had mentioned you were going to post on the blog. I thought Carol had posted that, but HRH probably best. Why don't you just reach out to me directly, and I'll have Carla get those to you, or actually just send an email directly to Carla. So I'm going to put her email down here, and you can reach out to her. So I'm just putting Carla's email here. Reach out to Carla directly. She'll get you those. I had my consult with you last week. I forgot to ask. After I tripped 2 weeks ago, I started to feel my bones go off track or detour when I nod. Yes. Is this my atlas sublux? When does the subluxate axis become dangerous? Yeah, I mean, Deanna, well, it's always possible you have a severe subluxation, which is really what they're talking about in that type of setting. I think it's extremely unlikely that you do. And so hence wouldn't really commonly be dangerous. Now, obviously, if you had a severe subluxation, the kind they're talking about, usually there's lots of other symptoms with it too. And, that's something that could just be seen on a standard x-ray in the ER. But if we're talking about just out of position, which is a very different concept, that's something you may want to see an AO or NUCA chiropractor about. James, is a topic that I'm really interested in knowing how to improve. HRH or the exercises or anything else you recommend which will help the vagus nerve. No specific exercises. The biggest issue is to fix the CCI. Now, there is an excellent group of physical therapists that does do some vagus nerve work. Let me go ahead and pull that up for you, and let me get that shared. So this Institute of Physical Art is a great place to go. So the Institute of Physical Art or instituteofphysicalart.com is a great place to go. Well, number one, they're a national group of highly trained physical therapists. That's why I like them. That's why I've always liked them. And then number two is they do vagus nerve work. And they've got a national network that you can find people on this website. So that's a great place, I think, to start if you're looking for someone who really knows how to do vagus nerve type physical therapy. In the meantime, the answer is usually to obviously treat the instability, but you may want to start there and or see a NUCA or AO chiropractor where they can get everything back in place. Oleg, aside from being overdiagnosed in people, could you please explain tethered cord? Is the filament supposed to be free floating or attached at all? What is tethering then? Why does it happen? How does CCI cause it for some? Please name, post, list of tests we should ask to make sure Veterinary doctors do their due diligence. Yeah, Oleg, I'm concerned about what I consider the overdiagnosis of tethered cord. Now, you got to realize that tethered cord is going to come in two flavors. The kind we're talking about is what's called occult tethered cord, or OTC. And then there's tethered cord. When it comes to tethered cord, that's easy to see on a MRI. So if we look at MRI tethered cord, see if I can find a good picture that shows you what a regular tethered cord would look like. Here we go. So let me share that. So here we have the usual tethered cord, not occult, but the usual. Now, normally the end of the spinal cord stops way up here, but now we have a spinal cord way down here, or ending way down here at L4-5. So that's the usual tethered cord. Occult tethered cord is very, very different. So again, just to compare here, normally the spinal cord is stopping way up here, and a tethered cord, it's pulled way down. Now that's very different than occult tethered cord, or OTC. An occult tethered cord, which is pretty controversial in the neurosurgical community, meaning if we were to ask 1,000 neurosurgeons as to whether they believe that occult tethered cord exists, we would probably get answers from 999 of them that they don't think it exists. So that's the first issue. Then we get into what is it? The theory is that if you've got craniocervical instability more due to EDS, then you may be pulling on that cord. What I tend to see more commonly is the surgical correction often involves treatment for vertical instability is to pull the head up by 1 centimeter or 2, hence putting more pulling pressure on the cord. And then people need to be detethered. Now, do they need to be detethered? No one knows. There's no research on this. There's nothing I can go back to say, yes, in this particular study, they detethered a bunch of people, and then they didn't do it over here, and the people they detethered got a lot better than those that didn't get detethered. To answer your other question, the cord has a phylum on the bottom, and it's attached in everyone. The concept with tethered cord is they go ahead and cut that. And that's a permanent change to the central nervous system. So that's a very invasive procedure, regardless of how it's done, meaning that you can't go backwards. You can't add that back in if you get worse after they detether your cord. So that's the problem. It's a permanent change to the biomechanics of the central nervous system. Another problem is we don't have a good way to diagnose it. There's no MRI finding that I can go through that will accurately identify tethered or occult tethered cord versus not. Hence, there's some physical exam things that can be done. The concept there is that if you put additional pressure on the cord, the patient gets all these symptoms. But really the biggest thing that I see that where this is usually diagnosed is the presence of abnormal urodynamics. Concept there being that the nerves going to the bladder aren't working real well because of the tethering. The problem is lots of people with just standard old back pain have abnormal urodynamics. So distinguishing those people from tethered cord is pretty hard to do. Diana, is it dangerous to see AO if there's transverse ligament laxity? No, not in my opinion. Tosca Dunn, after my parachute accident, the back of my head was skeletal. I'm not sure what that means, was skeletal. So maybe if you can tell me a little bit more. Liam, I just learned that some ligaments are taut in their neutral position. They all should be. Is this the case for the alar ligaments? Does this negatively impact healing after PICL? All ligaments should be taut in their neutral position, unless we're talking about like a capsule. So for instance, a shoulder capsule, you've got to have a lot of motion allowed there. So the front of the shoulder capsule has folds, and that allows a lot of motion. So the folds are accordion-like here, and then the accordion gets stretched out as I externally rotate. As far as other ligaments like alar, those should be taught. Meaning, I've never seen a picture of the alar ligament where it was loose and normal. Diana, how do we strengthen the multifidus muscle? Yeah, so Diana, you really can't strengthen these things until you get approved for that. A lot of CCI patients have ligamentous laxity and find that strengthening flares them up. So we've got to get to a certain level of stability before approving the patient to do that. And strengthening the neck muscles can be as simple as doing some of the exercises we have online and just sort of daily use. Now, there are muscle strengthening devices out there, everything from something called a gyro stim, which also deals with balance, to something called a multi-cervical unit. But they tend to be a little bit more aggressive, and a lot of our CCI patients can't tolerate that. Floyd, hey doc, my MRI was really clear. My 3T MRI isn't that clear. So there seems to be a small amount of fat, but not as much as your second MRI. It's like a steak with some small, fine fat parts. Yeah, so that just means that the atrophy is not as severe, which is a good thing. Deanna, thanks, Dr. Centeno. What are some examples of symptoms one might have with a dislocated atlas? Of increased wobbling, dizziness, new vertigo, nausea, in addition to weird zigzag then when nodding? Yes. Those are pretty much all symptoms of upper cervical issues. Now, if you're really concerned, I would just go into the ER and get some cervical x-rays done. And if there's a severe dislocation, they'll tell you in a heartbeat. I suspect that it's much more likely that it's just out of position rather than dislocated, and that something like an AO or a NUCA chiropractor might be very helpful. Tosca, I've been saying for 20 years that I'm a bad steak. Love the analogy. That's a good one. Oleg, last live stream you talked about triggers for CCI, and you mentioned that EDS and trauma being only proven ones. I believe when people talk about triggers for CCI, they often mean what triggered the hypermobility. I think that's the question most are asking. What seems to trigger pathological? Yeah. So Oleg, we don't know much about this kind of research. I wish we did have more that we knew about this. As I said before, when it comes to triggers, those are usually functional medicine terms. Things like mold or CIRS triggering this. We don't have any research on that, so nobody really knows whether that's the case. I think I shared with you guys the one research study that exists for CCI and Lyme, kind of a low-level study, meaning that if we did a higher-level study where we looked at patients with CCI in the population who had Lyme on those particular tests, which aren't really accepted in the traditional medical community anyway, but let's just go for it or go with it for now. And then we looked at the number of people in that same area of Germany who had no symptoms. Would they come out similar on those tests? We don't know any of that. So again, these are all functional medicine concepts without much research behind them. We may find some research that backs them up at some point. But as far as triggers causing CCI that are not trauma and EDS, we won't recognize those until we get some research on that stuff. Oleg, Doctor, not sure if you mentioned this live stream. You said before, I could see in my MRIs to check for atrophy. How best? Google Drive link. Yeah, so the best thing to do there is just send them to Carla, put her email address there, and just copy and paste your full CD, send it via one of the file transfer services. I'm happy to take a quick look at it, see if it's there. Barbara, I know there are risk factors for osteoarthritis. What actually causes it? Also, if someone has knee osteoarthritis, are they likely to get it in the hips or other joints too? Yeah, I mean, the risk factors for osteoarthritis are being overweight. And that's probably as little as 10, 15, or 20 pounds overweight. Metabolic syndrome, high triglycerides, prediabetes, high blood pressure. In addition to that, there are probably genetic predispositions. Some people are more likely to get it. Obviously, there's wear and tear predispositions. We tend to see it more in people who have labor jobs, things like that. As far as getting osteoarthritis in other joints, that's possible for sure because you're changing the biomechanics of how you move. when you get it in one joint. Spencer, in recent imaging studies, I've been diagnosed with both a bulging disc, compression of the brachial plexus, and the scaling areas TOS, in addition to upper cervical CCI. First PICL 8 weeks ago. Recovering PICL was going great, but I am experiencing progressively worsening hand, muscle, and shoulder weakness, as well as intrinsic hand muscle atrophy, is something you would recommend in the short term to assist. Yeah, I think we've looked at this. I couldn't find much atrophy in the hands, even at that point. So I'm not quite sure what to tell you there as far as how to proceed, but best to reach out to your doctor directly, because I know that that perception that there's atrophy there has been going on for a long, long time. So that's more of a complex question. Diana, I think I understand working on getting with an AO. My recent cervical spine x-ray indicated that it might have degeneration at C7T1. Will posterior PRP help with this degeneration, or is it game over now with that joint? Am I likely to get arthritis there? Diana, we all get, well, not all of us, but most of us get neck MRI degeneration as time goes on. It's pretty normal. It's a fact of life. It's about as important generally as wrinkles on your face, meaning it doesn't mean much until it's causing symptoms. So I wouldn't worry too much about it. It's kind of just part of getting older, and we try to mitigate it as best we can when it causes symptoms. As far as regrowing you a new spinal segment, no, that's not possible with existing technology. I doubt it will be in my lifetime. Maybe yours. I think you're younger than I am. You look younger than I do. Pia, can you show how to know what is left and right in MRI? If not marked obvious, is there a code somewhere? Pia, that is a good question. It's backwards. So the left of your screen is always the right of the patient, and the right of the screen on an axial, meaning we're looking at the top-down view now, but the right of the screen is always the left of the patient. And bizarrely, they chose, and the reason why that is that way is they chose to do a slice through the person, but they're looking at the slice like this. They're looking up at the slice. So it makes sense if you think of it that way, where it's opposite. I have no idea why they chose to do it that way. It would have been much simpler to put the right of the patient on the right side of the screen and the left of the patient on the left side of the screen. That would have made common sense. But I suspect it's just a holdover from some of the early days of MRI and how they had it all aligned and arranged. So I think that's what's happening there. But just realize it's opposite. Right of the screen, left of the patient, left of the screen, right of the patient. Ben, if ligaments at the CCJ can't get tight enough the way they once were, will there always be muscle atrophy issues since we always have to make up for some degree of instability? Could be, it's possible, but the goal obviously is to mitigate those as best we can by tightening up those ligaments, but it's possible. Okay, well, I think I have answered a good number of questions. Any other questions, guys, I can answer about this? I know this is something that I've been asked a couple of times to go over, is how you would read those MRIs. So any questions I can answer at all? Can osteophytes at the atlas get bigger and get dangerous at some point? I don't think dangerous. Realize your body is putting those osteophytes there to try to stabilize things. So they could theoretically cause some problems. Sometimes osteophytes do, but your body is doing that to try to stabilize things. So not dangerous. Any other questions, guys, that I can answer? Floyd, is there a particular diet to reduce fat infiltration while doing exercises? No, realize that the fat doesn't have anything to do with being fat. It's just when you have muscle degeneration in the body, it's always replaced by fat. Other questions I can answer? Okay, guys, I'll start wrapping this up. Realize that I won't be here this Friday. And then there may be a gap in Facebook Lives there. I'm going to be out for a number of weeks. And I will try to see if I can sneak 1 or 2 or 3 of these in while I'm gone. Probably what I'll have to do is maybe schedule it for the morning rather than at 1 p.m. Mountain. So it might be something like 8 a.m. or 8 a.m. Or 7 a.m. Mountain, obviously later Eastern, 2 hours later, just so I can do something like that. But we'll see how that goes. Danny, I have 5 questions. Can we email you while you're away? Oh, sure, Dan. I'll be checking emails while I'm away. That's going to continue. So nothing really changes there. I'll also continue doing telemedicine while I'm away. Ben, my muscles are a big issue for being atrophied. I stay out of the collar as much as possible. Have you had patients relieved of muscle fatigue from PICL? Sure, but the collar is not a good idea. So just realize the collar increases that atrophy. So the longer and more dependent, the longer you've used a collar and more dependent you have become, the harder it's going to be to get you out of a collar. That's just every week that goes by of wearing a collar digs that hole deeper and deeper and deeper. So then you have to climb out of the hole. Obviously, if you haven't been wearing it very long, the hole is not very deep. If you've been wearing it for a very long time, the hole is extremely deep in which to climb out of. So just some FYI there. Okay, guys, that sounds great. Thank you so much. I won't be here this Friday, like I said. And then after that, we'll have to see when I can get a few of these Facebook Lives in over the next 6 weeks. I will be still doing telemedicine. I still will be checking my emails, responding, all that good stuff, which I generally do when I'm out, primarily because if I don't, by the time I get back, it's overwhelming. So I try to stay up on all of that. Rigolab, have you had patients that experimented with hyperbaric oxygen pre and or post procedures? I've seen studies, HBOT stimulates both stem cells and tissue reconstruction. I don't know that we have a lot of good research that HBOT stimulates stem cells and tissue reconstruction. We may have a little bit here and there. We have a few patients, maybe 10%, that do this, and they seem to like it. I don't know if it's actually associated with any improved outcomes, but I don't think it'll hurt for sure. Diana, how do you know when you're gaining muscle strength and neck after wearing the collar? Are there signs versus instability? Well, if you've got normal muscles there, the first thing would be that you can obviously tolerate being on the collar 24/7, 365. Second thing would be you become more resistant to injury and or this getting out of place because those muscles are stabilizing and protecting things. Okay, guys, thanks so much for watching today. And again, what we talked about today was this idea that you can read your own neck MRI for muscle atrophy. So I would encourage you to do that. And I'll be on a little break here, but I'll probably be trying to get a few of these in. I definitely won't be here this Friday or Monday, though. Thank you so much.